Yes, it's okay.
Okay, perfect. Thanks. So thanks, Monse, for the invitation. So today we will present you what all the work we did on the French National Medical Administrative Database. So first, I will introduce you a few words about the Health Data Hub. So the Health Data Hub is a public interest group created following the laws on the organization and transformation of the French healthcare system, and it was created 2 years ago. So it's mostly financed by public funds. So in France, we have a lot of database, and we have a very rich database, but all the database are scattered, and it's very difficult to access to all the database because the procedure was not explained everywhere. It's for that the Health Data Hub was created, to have a unified and transparent and secured access to all the database in France. We have 4 missions in the Health Data Hub. The most important one is to set up a performance platform enabling public interest project leaders to access and combine a massive data source using high computing power to run complex research algorithm. The Health Data Hub provide also a collection of database, and we provide access, a unique gateway to access to the Health Database. We also provide some several tools to bring together key stakeholders and to foster a health data culture. So we have a data catalog inside the health database. We don't collect data, but we just have a copy of some database, and the list of the database is decided by the Ministry of Health. In this catalog, we have the French National Medical Administrative Database, which Gaëlle will give you some details later. And we have also other medical administrative database and some clinical database, for instance. To give you some details about the platform, when a project is accepted by an ethical committee, we receive the data in the Health Data Hub, and we will create a project space. All the project space are secure space with a virtual desktop. On it, we don't have internet, but we can have different software to analyze the data, like different language, different software to do some data visualization, to do data storage, or to work with image, for instance. And we are improving the list of the software during this year, and we will continue to improve the list of the software. So now I will let Gaëlle and Cécile to present you all the job we did to do some standardization on the French National Medical Administrative Database.
So the French National Medical Administrative Database, the SNDS, is the connection of 3 main sources of data: hospital data, healthcare insurance system data, and the causes of death. So on the left of the slide, you can see a simplified schema of the SNDS. The structure is scattered, and the name of tables and variables are so abstract. So it needs a lot of time in data management to understand the data and to perform some researches. So I'll give you some key numbers to measure the complexity of this database. So it is composed of more than 180 tables, 4,400 variables, and 250 terabytes of data. This data has been collected since 2006, and it covers almost the entire French population. The SNDS is used to carry out projects in several fields. For example, the project EPIFAR, it involves analysis of about 15 million people from 50 to 74 years old to assess the link between the vaccine and severe forms of COVID, in order to show important reduction in the number of people who develop severe forms after vaccination. There were two time winners of the Eden call for proposals. The first one has the objective to conduct studies on COVID. So we therefore focused on the table identifies as priorities and containing medical information. And the second call for proposal aims at the extension of the scope of the data, the use of all possible information contained in the SNDS, and the extension of the temporal scope. So for these two projects, the Health Data Hub works with the Bordeaux Pharmacoepidemiology and the Paris Hospital to harmonize all processing rules at national level. So the transformation of the SNDS into OMAP-CDM consists in three main steps. The first one is to establish a correspondence between the fields of the two formats. The second one is the implementation of the ETL by writing scripts to switch from one format to another. And the last one is to check the quality of the database. And to carry out the project, many actors and professionals are involved. They are data engineers, data scientists, medical interns, database experts, and our partners, Bordeaux and Paris Hospital, APHP. To transform the ETL, it is an iterative process. At the beginning, we have to write a mapping rule in natural language. Then this rule is checked by database experts who have the knowledge of the source data and Eden. Then, when a rule is validated by both of them, we code it in secure models, and we build a final table validated then with the experts and Eden. And if any problem occurs, we are back to the first steps and we iterate the process. And when we have a stable version of the ETL, we can run data quality tests, which will eventually lead to correction. So on this slide, you can see an example of the building of a visit occurrence table and some issues with different difficulty level we solved. So the first one can be, how can we identify unique visits in the claims table? So it's a question with a medium difficulty because we need 10 keys to build, to identify a unique visit, for example, a person identifier, visit dates, etc. Then you know that the SNDS is divided into two main products, hospital data and healthcare insurance data. And some data is stored in both products, so we have to avoid duplicated data in the target database. So we have to delete some data from a healthcare insurance database, and it is based on a categorization of the care sites related to the visits. So it's a very high difficulty level. And then an easy question can be, how can we know if a patient died at hospital? And this information is already stored in a dedicated field in the source data, so it's quite easy to answer this question. And then to transform the data, we use DBT, which is an open source tool, and it is used to transform data, so it corresponds to the T in ETL. This tool is based on secure models and macro to define transformations. And when DBT runs, the model are materialized into the target database. In our case, it is in Postgre.
So now, as you all know, one key step of the transformation into the OMAP-CDM format is to map the vocabularies into standards 1. So in France, we have a particularly important amount of work since we have 70,000 source concepts, and which describe procedures, drugs, biological acts, rehabilitation, and medical devices. And so to map these terminologies, we had to lead collaborative work since it calls on different skills. With Gaëlle and Lorien, we don't have medical skills, so we had to call on medical intern students' skills to map the vocabularies and double proof the mapping. And we at Health Data Hub coordinated the work. We also checked with Bordeaux Pharmacoepi the validity of the mapping, and in the end, ODC provided the last validation and integration of the ODC vocabularies. So, as I told you, in France, we have numerous terminologies, so we would like to present a few to you. First, CCAM is used to code medical procedures, and it is a really huge term. It is, as it is for reimbursement purposes, it is very detailed. So we decide to map only the codes that represent 80% of the records, and under more than 8,000 codes, it means that we only mapped approximately 700. So the others were mapped on the chapter level, which most of the time correspond to quite exactly to one SNOMED CT code. The CSAR is also used to code procedures, but it is only in the fields of physical or speech therapy. So again, we use the same process. We mapped the 80% most frequent codes, and for the others, we mapped on the chapter level. Then for drugs, this is still an ongoing work. We already mapped approximately 500 codes under, I think it's 40,000 codes. So we mapped for one project I will present a bit later. And for NABM, this time, as it is quite a small terminology, we mapped on the code level. And last, the LPP, NABM are used to code measurements, which can be understood as procedures too. That is to say that these codes only the act that was provided and doesn't provide any results. So, for instance, with this terminology, we can say if someone had a PCR test, but we can only know it happened, but we don't know if it was positive or negative. Last, the LPP codes are devices. These are two very precise codes in comparison with international standards. So it was impossible for us to keep all the detail. Thus, they are all mapped on the chapter level. Then we would like to present you a few results on data quality checks on the first OMOP-CDM database we have. So to illustrate the quality and checks we run on our ETL, here is an example on a glucocorticoid study conducted by PEL Lyon on our Health Data Hub platform. So this project is the first one conducted on the SNDS transformed into the OMOP-CDM format. So in 2020, EMA entrusted an observational study to IQVIA on glucocorticoids and the treatment of COVID. So the Health Data Hub was in charge on transforming the data retrieval from the SNDS into the OMOP-CDM format. PEL Lyon was chosen as French referent. And as you can see, it was a cohort of approximately 300,000 patients, and which represented the 200 gigabytes of data retrieval from the SNDS. And after transformation, it was only 30 gigabytes of data. So we can see one key interest of the transformation into the OMOP-CDM format. And also, of course, the reducing of the number of tables and variables, as Gaëlle told you before. So these are results from data quality dashboard. So these are only the general results. As we can see, these are very good results. I think you probably all know the three categories from plausibility, conformance, and completeness. But I would like to just moderate the results of plausibility. As I told you before, we don't have any results of measurement in our database. We don't have the fact that someone had a measurement done. So and with data quality dashboard, when a value is not available in measurement on a measurement line, it is considered as passed. So I think that if it was considered as failed, we would have a really lower result. So here are a few results on Achilles. So we can visualize a few data. For instance, we have a 50-50 male-female distribution. And the age at first observation is quite high. So we have quite an age cohort, but it was conformed to what we expected from people from a cohort of people hospitalized for coronavirus. And in data density, you can see that visits are higher than other domains, than conditions, procedures, and measurements. But it is because in France, most of the time we have one visit per condition, per procedure, per measurement. It happens in a outpatient visits. It happens a lot of times. So this explains why visits are higher than the other domains. So then we would like to present a few focuses on different codes. It is really important for us because with the SNDS, it is really difficult to have such visualization. So we were very happy to have those. First, a focus on the COVID-19 code. So here, I think we have approximately 2 or 3 different COVID-19 code in our database. And here we can visualize the two waves of the pandemic. Another COVID code, it is a suspected COVID-19 code. Here we can also see the 2 waves of the pandemic, but one particularity, since the first spike is really higher than on the previous slide, it is explained that the fact that during the first lockdown, we didn't have the tests. We didn't have tests to assert that someone really has COVID. And last amusing example we'd like to show you is a focus on dental scaling and polishing codes. So during the first lockdown in France, dentists were closed as probably as everywhere in the world. And in France, you can see the 2 August months. These are the holidays, and French people have other things to do during the holidays. So to conclude, access our SNDS data is a really complex process, and you have the necessity to attend a course. Since it is complex, the healthcare insurance, the national healthcare insurance, wants to be sure that people understand the data. So this complex relational data model is difficult to understand, and which might lead also to a potentially biased data interpretation. And as I told you before, it is really difficult to provide statistics, and there is no unique method to provide reliable statistics on the data, and a difficulty to visualize it as we did with Achilles. So the interest for us for transforming to the OMOP-CDM format is to have a patient-centered database, which is not the case in our source data. To have an easy access to documentation of the OMOP-CDM format, and to provide fast generated statistics of the data through ODC tools. So thank you for your attention.